amblyopia. As we know, amblyopia is it is a cortical developmental disorder.
Ma'am, excuse me, ma'am.
Hello. Yes.
Ma'am, I can't see your screen.
Oh, okay. I have. I'm sorry. I thought I have already shared.
No problem. Now I can see it here.
Okay.
Please, ma'am.
Okay. So today I will be discussing on management plan of amblyopia. So as we know, amblyopia, it is a cortical developmental disorder where these cortical changes entice the visual cortex to prefer one eye over leading to a number of functional deficiencies in the eye, like decreased visual functions, impair motor signs like decreased eye-hand coordination, poor saccades and persuade. Uh, uh, Hello.
Yes, ma'am. Yes.
Is this screen visible?
Now it's visible, ma'am.
Actually, I'm on with. I'm so sorry.
Yes, ma'am. Yes. It's working now.
Okay. Okay. I'll put it here. So it is a cortical developmental disorder where these cortical changes will entice the visual cortex to prefer one eye over leading to a number of functional deficiencies in the eye, like decreased visual function, impaired motor signs like poor eye-hand coordination, poor contrast sensitivity, etc. So amblyopia, it is a binocular problem which is manifested monocularly. So the reduction of visual acuity, it is just a symptoms of true problem. So at first we need to understand what is amblyopia, and then we need to move forward to the management part. So the goal of amblyopia management is, so always amblyopia, as I told, it is not an eye with amblyopia, it is a child with the amblyopia. So when we are treating amblyopic patient, we should consider them as like a whole person with the amblyopia, pathology of amblyopia. So we need to help to improve the eye teaming, focusing, and tracking skills. So we need to improve their visual comfort, acuity, binocularity, age, and efficiency. And when we need to help the patient to develop or improve fundamental visual skills and abilities. We need to change how a patient process or interprets the visual information. And we need to know what would be the perfect amblyopia therapy to patients and parents as well. And obviously it should be quick, safe, and easy to administer, and cost effective, and it should be well maintained. Here, I have divided management plan into two different portion. One is in classical treatment options, and next one is in modern treatment option. So in today's lecture, I'll be discussing about classical treatment options of amblyopia, and in my next lecture, classical treatment options. So moving towards
Excuse me, Ritu ma'am.
the classical treatment options. The first.
Excuse me, Ritu ma'am. Can you hear me, ma'am?
Yes, I can.
Yes, ma'am. In between, I don't know why, but in between your sound is like breaky.
Okay.
So I
But
guess, yes, ma'am. Can you please share it again? And you can see in your screen there is a play button. If you press this play button just below, yes, it will work slowly, smoothly.
Yeah.
One comment over here. Most likely you are presenting from phone, so whenever there is a SMS or any call is coming, so automatically it goes to a mute mode. So if you can block your call or
no, I'm not receiving any message or call. No, I have not received any call or message right now.
because that's the only possibility to mute your voice automatically in between your presentation. Otherwise, there should not be any issues.
Maybe
just cross
actually
check
I'm using, yeah, I'm using earpod, maybe because of that. Actually, I'm using only one.
Yeah, but your voice is going off in between the presentation. That's the only comments from my side. Go ahead.
So I guess it will be better
is
if
still
you
same?
keep. No, ma'am, it's coming smooth.
Okay,
If you have like non-disturb mode on your system, then it will also work betterly.
let me check. I tried with that, but
Okay. Okay.
it did not work in my phone. Hello.
Yes, ma'am.
Now, is it okay?
Yes, ma'am. It's okay.
Or is it still same? Please let me know in between,
Okay.
because most of the time it used to happen like I used to win mute and I was not aware of that.
Okay,
I'm
ma'am.
so sorry for the disturbance.
Okay.
Okay, I'll continue with this one. So now the first point is eliminating any obstacles. The first treatment approach will be eliminating any obstacles to the like any obstacle that is disturbing the path of vision, like childhood cataract, severe congenital ptosis, or any corneal opacity. This should be treated as early as possible, just to prevent the stimulus deprivation amblyopia. And in case of congenital cataract, this should be removed during the first 2 to 3 months of life. And in case of symmetrical bilateral cases of cataract, this should be removed in the interval between the surgery interval between should not be more than 1 to 2 weeks. And in case of traumatic cataract cases, if the child is less than 8 to 10 years, the cataract should be removed within few weeks of injury. Yeah. So the next treatment plan or the approach is classical lens prescription. So here the refractive correction was done based on the cycloplegic refraction, where there was a concept of giving maximum plus with maximum visual acuity. So now I'm talking purely, please don't get confused. How I have divided management like this session is in two parts. Today I'll be talking only about classical management, like how it used to happen before. I'm not talking about modern approach, like what we are doing, or as a vision therapist or as an optometrist, what we are doing. That is like totally two. I have divided into two parts. Today I'll be discussing only about classical part. So don't get confused or so we'll be discussing in that class as well. But today I'm discussing only about classical part. So here, how they used to correct or how they used to give the correction to the patient is giving maximum plus with the maximum visual acuity, and where full correction used to be given to the astigmatism, myopia, and in anisometropia. But in case of hypermetropia, it used to, like, depending upon the cases. In case of esotropia, they used to give full correction, but in other cases they used to decrease the correction and they used to give. But in case of anisometropia, they used to give full correction. So the goal of prescribing full correction was is to provide the clear retinal image. And even like every 6 to 8 weeks, the follow-up used to be taken. And many studies had shown the success rate of amblyopia treatment with this kind of prescribing method. If we see the pediatric eye disease investigator group, where they have concluded that in the 77% of amblyopic subject, visual acuity was improved, and in 27% it was resolved. And in chain et al. Study, here they concluded that with the optical correction alone, 93% of the subjects, their visual acuity was improved, and in 45% it was resolved. And the study done by pediatric eye disease investigator group, where they found that the 25 to 35% of the patient visual acuity was improved. That too in case of anisometropic amblyopia and in case of strabismic amblyopia, only with the full correction. Like they had not gone with any therapy, only with full correction. 25 to 35% of anisometropic amblyopia and strabismic amblyopia subjects were improved, or their visual acuity was improved. And in the study done by the Stewart et al., they found that in case of refractive amblyopia, like after 16 to like up to 16 to 22 weeks, the refractive correction or the acuity has been improved up to like within 16 to 22 weeks. And many studies showed that like after 18 to 16 weeks, still like we should give a time to the patient for from 6 to 18 weeks. And we need to see like either a visual acuity is improved or it has not been improved. And if the visual acuity is not improved after 18 weeks, then they used to initiate for the other therapies. So when the patient is not responding, or if the patient do not respond to any refractive correction alone, and their visual acuity is not improving with the correction, then they used to go with the other therapy like patching, atropine penalization, or benzoator filters. Now I'm moving to the next treatment approach. Next is occlusion. Occlusion therapy or patching therapy, it was started from 18th century and still till now it has been practiced. It is being practiced. And the goal of occlusion therapy is to cover the good eye and to stimulate the amblyopic eye. This therapy is initiated for the child who doesn't improve with the refractive correction alone. As I had told before, so what previously what it used to be done, like from till 18 weeks, like they used to observe the patient, either their visual acuity is improving with the correction or not. After that, if it is not improving, then they used to go with the occlusion therapy. So now moving towards type of occlusion, it has been divided into total occlusion or partial occlusion. In total occlusion, all the light is prevented from entering the eyes, so which is done by rubber occluder or gauze pad occluder, where light, like they used to occlude totally so that light cannot pass into the non-amblyopic eye. And in case of partial occlusion, here it is done by transparent nail polish or higher plus lenses, where the main aim is to cut off the light entering the eye, like so that full light cannot go inside the non-amblyopic eye. And conventional occlusion is occluding the good eye or occluding the non-amblyopic eye. And inverse occlusion is occlusion of amblyopic eye so that eccentric fixation becomes less fixed. And in case of full-time occlusion, here it is like how they, if they used to prescribe full-time occlusion, how they used to do, like whole day the patient has to occlude their good eye or non-amblyopic eye, and while going to the before sleeping, then that time they have to remove the occluder or occlusion. And in case of part-time occlusion, it has been divided like short-time occluder, where they used to occlude their eye for shorter period of time, like while doing some work or while watching TV, etc. If I'm going very fast, please let me know so that I'll be a little slow. And now moving towards the other study, like how the occlusion was going and how was the success rate and what was the result from that. According to pediatric eye disease investigator group study, they found that daily 2 hours of occlusion has been like more same effective as 6 hours of daily occlusion. And according to the Stewart Holmes study, they found that a patient with logmar acuity of 0.7 to 1.3, where they found that 6 hours occlusion is as effective as full-time occlusion. Here in this study, they found that 6 hours is equal to full-time occlusion. And in case of pediatric eye disease investigator group, they found that 6 hours is equal to 2 hours occlusion. And in Rustin et al. Study, they found that 2 hours of daily patching with 1 hour of near activities is as effective as prescribing the 6 hours of daily patching with 1 hour of near activities. And in his study, he did like he took a group of subjects where uh, hello, where one group was given therapy for 2 hours with the near activities, and another group was given like occluded for 6 hours and given 1 hour near activities. And they found the result was same in both the groups. And according to the another study, they found that in case of severe amblyopia, prescribing 6 hours of daily patching with 1 hour of near activities was as effective as full-time daily occlusion with 1 hour of near activities. So, what is the summary of this study? What we found that children with less than 7 years and the visual acuity between 6/12 to 6/24, the patching for like 2 hours and 6 hour patching there was no any difference. The effect was same. And in another study, what they found that the children with less than 7 years with the visual acuity of 6/30 to 6/120, here they found that the group with the 6 hour patching and the full time patching, there was like no any difference. So even they can go with the 6 hour patching. The effect was similar. And the children, and in their another study, they found that the children from 7 to 18 years and the visual acuity from 6 to 12 to 6/120. Here they found that 2 to 6 hours patching lead to at least 2 lines improvement, but the compliance is poor in age if it is more than 13 years. So according to them, like if the child is more than 13 years, so the improvement or the compliance was very poor. And the child and the subjects where the study was done, like children who are less than 8 years, this is another study where they found that their visual acuity was in between 6/12 to 6/120. So patching 2 hours is better than spectacle alone. What they found that if the subject who are less than 8 years, if their visual acuity is in between 6/120, they found that rather than giving only optical correction, if we give patching, then it will work better. Like if you are giving 2 hours patching with optical correction, so even it will work better. So that was the conclusion of that study. So now moving towards the disadvantage of occlusion. As we know that when we are occluding our good eye or non-amblyopic eye. So it impairs the binocular vision, which affects visual skills such as depth perception or eye teaming. And just imagine, like we have 2 legs. Suppose if we get fractured in one leg, and instead of treating that fracturing leg, like the leg which has been fractured, if you are asking patient, okay, you have to walk with that fractured leg, how that patient would manage his day-to-day activities? He cannot write. So same thing happens in amblyopia. Here always, even in my practice, I explain to the patient that when you want to treat that fractured leg, you should treat that fractured leg with the help of another leg. It's not like you have to stop walking with the okay fine leg, and if you start walking with the fractured leg, then obviously that patient will suffer, and he will be suffering in his day-to-day activities, in his professional life, mentally, socially, everywhere he will be affected. So we need to keep these things in our mind. And what happens, like when we occlude their good eye or occlude one eye, it reduces the field of vision, and we are disturbing the binocularity. So patient, they will feel difficulty while playing, while copying from board. So their performance will reduce, and even the ability to learn or to perform, it will be reduced. It may lead to double vision, and even it decreases the vision of normal eye. And here, like if you are occluding or if you are putting patch in somebody's eye or even in our eyes, like what happens, like their confidence will reduce by its own, and even self-image, like it will decrease. And even the patching or occlusion therapy, it is very difficult to maintain for both the parents and the child, or to the kid. Both parents and child psychologically disturbed. Like I have seen, like before moving towards the vision therapy, or like after moving towards the vision therapy, or after moving to the vision therapy department, I have like heard many complaints or feedbacks from patients saying that before I was not aware of vision therapy, and it was very difficult to convince my child for the patching. And even if we have to go for party and all, I don't feel comfortable to patch his eyes, because all my relatives or my friends do ask what has happened to his eye, why you have uploaded, what is the reason. So they will be asking thousands of questions. So I don't feel comfortable to patch his eyes, and I don't feel confident in front of my friends. So either we don't take our kids for the party, or like we don't put the patching. Like that was the compliance, or that was the comments I used to get from patient. But after vision therapy, that was the scenario was totally different. So those things I'll be discussing in my next lecture. And even many studies have shown that patient used to get allergic skin rashes, and obviously cosmetically it is not at all acceptable. So these all are the disadvantages of occlusion. So we need to consider all these things. We need to consider a child who like considered like same thing what I gave you example. One leg has got fracture, and if you're asking to perform or things, or you're asking the patient to run with that fractured leg, then how that person is going to survive, or how that person is going to fight, or how he is going to deal his day-to-day activities. Now next method is penalization. This is a therapeutic technique which is performed by optically defocusing the non-amblyoptic eye by using cycloplegia, that is 1% atropine, or by altering the eyeglasses lenses. So what are the indication? It is like obviously it is better than occluding the eye, because cosmetically it is better. That people will not know that that he is undergoing this therapy, or he's occluding his eyes. Cosmetically it is appealing, and it can be used for the mild degree of amblyopia. So, and the disadvantages are decreased visual acuity in good eye, which hampers binocularity. Obviously, like if you are occluding better eye, and if you are asking the patient to deal day-to-day activities, or to do his day-to-day activities with non-amblyoptic eye, then obviously he will feel difficulty. And even when he is driving, when he is eating, when he is doing all these activities, you will face difficulty, because we are hampering the binocularity. And it can be given only for the mild amblyopia. And many studies have shown that most of the patients, they complain of photosensitivity, and most of the patients, they have complained of allergic reaction as well. So these days, this penalization with atropine, it has been stopped. Like I have not seen many of the practitioners practicing this one, but still this used to be practiced before. So I'm discussing this one as well. And here in the study done by pediatric eye disease investigator group, where they found that children less than 7 years, and if their visual acuity is in between 6/12 to 6/30, so the daily atropine produces the similar effect as 6 hours patching. So they used to convince, like they found that even if the child, if he is doing 6 hours patching, rather than the patching with the occluder, he can go with the daily atropine. So the effect was similar. So they found that even instead of going with the daily patching, they can go with the atropine. And even one of their study, they found that we can only versus daily atropine penalization. That is like they took two group of study where they found that subjects, in one subject they did like penalization only in weekends, and in other subject they did penalization in like every day. And they found the result that there was no difference in between the weekend penalization and the results of weekend penalization and results of daily atropinization. So they found that the effect is same. So even the child, or even the individual, if they don't want to go with the daily atropine penalization, they can go with the weekend. They found that the result was same. And next is Banger turf filter treatment. This is a filter which is applied to the non-amblyoptic eye spectacles. Here the filter is available in different density. So what it does, it degrades the visual acuity of non-amblyoptic eye to predictable levels, to certain levels. So it will degrade, and we can get it in different density. So what are the advantages? It is better compliance than patching. It is like, at least if somebody is very far, they won't be able to see that they have like patched their eye and full time wear. So in the study, they have found that if somebody is doing 2 hours of daily patching and if they are doing full time use of the filter, the result was similar. So it was suggested that even the kid, they can use this filter throughout the day. And obviously it is compared to full-time patching, the binocular vision like disruptive was little less compared to the it one. Obviously there it will be disturbed, but still it was less compared to full-time patching or few hours patching. So disadvantages are picking around the filters is relatively easy, and filters may not be uniformly degrade visual acuity to the predicted level. So maybe like how much they want to degrade the visual acuity, it may not be degrade that much. So now the flow chart of classical approach to treat amblyopia. So what are the like approach they had, like they used to do before? So full refractive correction used to be given based on cycloplegic refraction, where full correction used to be given for astigmatism, myopia, and in anisometropia. And for all the patient after like follow-up used to be taken after 6 to 8 weeks until the amblyopia resolves or visual acuity stabilize. And if the amblyopia persists, patient were advised to do 2 hours of patching. And again, they used to be asked, like they used to ask to follow after 6 to 8 weeks to see improvement. And if there is no improvement in the visual acuity, again patching hours used to be increased from 2 hours to 6 hours. And again, follow-up is to be taken till maximum visual acuity is achieved. After that, patching used to be tapered and stopped, and it used to be monitored for amblyopia recurrence. This is the classical approach that used to happen or they used to do before. But this is like now this is not successful. Actually, why this we should understand why this classical approach is not successful. Before they used to practice, and even somewhere they may practice, but ideally if you see a kid or if you see an individual with an amblyopia, so you should understand that where we are lagging and what we are doing. So here, like in classical approach, amblyopia is treated as a monocular problem instead of binocular problem. So here we are forcing amblyopic eye to use by limiting the use of better eye. So what we are doing, we are forcing the amblyopic eye to use, like we are closing the better eye and we are forcing the amblyopic eye to do all the things. And the study done by Simon on 2007, like in children less than 8 years, they found that like in children less than 8 years who are successfully treated with patching or atropine, they found that recurrence of visual acuity was more than 2 lines, and they found that approximately 25% of the subjects experience of recurrence during the first year of treatment. And in the another study done by Jonathan and Holz et al., they found that the recurrence was similar for amblyopia treated with patching and atropine. And in their results, they found that most recurrence occur within the 3 months after cessation of treatment. So in their study, they found that like recurrence of or the visual acuity used to go back to the same level, or at least 2 to 3 lines used to go back to the another level, like previous level. And the study done by Repka et al., they found that the recurrence rate was 3 times greater in the children who had 6 to 8 hours of patching that was spotted abruptly than in the children who had 6 to 8 hours of patching that was tapered to 2 hours of cessation. And in their history, he found that in the children where they took out children and in the age of 7 to 12 years, they found that the treatment regimen of 2 to 6 hours of patching with the atropine and patching and near activities, they found that only 7% of the children experience or recurrence during the first year of treatment. And so here, like we need to see, like here, what he did, like they saw, like he took a study and they found that only 7% of the children there was a recurrence where they had done patching, atropine, and near activities. So And even he found that psychosocial impact of parents and patient was affected. And so he concluded saying that so we need to combine the behavioral training with the goal of targeting the plasticity within specific brain regions or specific cortical circuit. So as we know, so here, so the what we need to understand that we need to work on neuroplasticity. As we know, neuroplasticity occurs throughout the life. Neuroplasticity is the process by which the neurons can increase their connection with other neurons through sensory stimulation of learning and experience. Here, like in previous study, like or in previous, like how they used to treat amblyopia is only by considering the visual acuity. But if we see like many studies, and if we see the patient, like uh, not only the study, if we are seeing the patient in day-to-day activities, you will know like how that patient is affected, in which all field he has been affected. So in the Weber et al. Study, he found that he did study comparing the amblyopic and non-amblyopic uh, group of population. He found that in the amblyopic population, they have the greater difficulty in performing visually guided tasks like reaching, grasping, social relation, emotions in sports and physical activities. And in Nielsen's study, he found that amblyopia, they read more like the reading ability will be very slow, and their writing, reading, drawing, the ability will be very slow compared to non-amblyopic kid. So all these things we need to consider. We need to consider all these things while treating the amblyopia. In the Shua and Michael study, they found that amblyopic patient less likely to have to completed a university degree than those without amblyopia. So that will lead to low self-esteem, negative self-image, feeling of depression, frustration, and embarrassment. Here, the the kid or the individual, he has been affected with all those things. So what we have to do, only with the correction of the visual acuity, he cannot do his all activities like how non-amblyopic kids are doing. So we should consider all those things, and then we need to plan therapy according to that. So now, always, so when we are making the proper management plan, we should consider like a child with amblyopia, and we need to consider all the factors which has been affected in his day-to-day life or in his professional life or in his professional personal life, and how he is going to be affected, and where we can guide and where we can help him to get rid of his problem. So this amblyopia, it is binocular problem. We should always consider it is a binocular problem which is manifested monocularly. And the reduction of visual acuity, this is the symptoms like triggering things like to give us that, okay, his visual acuity is reduced. So this is the triggering factor. This is the symptoms that, okay, this child may get all this problem. So visual acuity is just a one factor, very superficial factor where he has been affected. So we have to treat all the factors which all area he has been affected. So a classical approach was based only to improve the visual acuity. So when we are treating or dealing the patient, we need to combine behavioral training with the goal of targeting about the neuroplasticity. And in my next class, I'll be discussing about modern treatment approach, where I'll be discussing about behavioral lens prescription. How do we do that with our patient? Behavior use of occlusion. How we can implement all these things in our daily, like in our routine when we're seeing the patient, and behavior optometric vision therapy. And so before ending, actually, I would like to discuss something with you all. Is we all are practicing in some clinic or in some hospital. So I would like to know like what all treatment plans you all are following or we all are giving to our patients, so that we'll get different idea like what we can do and what we cannot do. And even it will be more easier for me to discuss in my another lecture, like in the modern approach in the next class. So I would like to request everyone, please feel free to share like how we are dealing with this amblyopic kid in our clinic or in our hospital, or how we are managing this amblyoptic population. So just I would like to request everyone to share how they are doing in their clinic, so that it will be easy for me and for you as well. Like and even for everyone, so that in our next class we can guide, we can help each other. Okay, we can do this, we cannot do this, we should do it like this. So it is like working in a team and helping each other. So please feel free to share your things, and if any question or if any doubts, please you can write it down, or you can write, we can discuss here.
Well,
Thank you, Kapil.
Thank you so much, ma'am. Let's wait for a few minutes. So
Yes,
if
sure.
anybody wants to share any the concept, so I guess Oliullah sir, are you there?
Yeah, Kapil, I'm there.
Okay, sir. Sir, do you want to share anything?
I think it's a wonderful discussion on the like whole aspect of amblyopia management till now, traditional way, and it's nicely covered all the components which are there into it, and so this is the base of definitely of any amblyopia management to go through from baseline and slowly uh, adopt to a modern approach where it makes it more convenient. So today's talk was very elaborative to understand what are the scope in traditional mode of management and what are the limitations that it has. So everything into it. Well done. So if or suggestion we can discuss about this forum.
Thank you, sir.
Okay. Yeah, if somebody having questions, so we can definitely start with the discussion part of it.
Just wait for a few minutes. Asmita ma'am, would you like to share something?
So there is a question probably onto the forum. So if you Ritu wish to take the question and then answer.
Yes, sir. I'll just read. All amblyoptic children with, I think ma'am is sharing like how she's doing in her practice. All amblyoptic children with visual acuity less than 6/12, I prefer to the local ophthalmologist initially, and then refer back after treatment with orthoptics. We find these kids and parents are quite non-compliant with the treatment. Okay. Okay, ma'am. So, yes, thank you so much for sharing, and it's nice to know that. So, in our next lecture, we'll like I'll be discussing about the modern approach, like what we can do further for that kid, or how we can implement in our clinic. So, I'll be discussing on that. Yeah. So, anybody else, like if you all like to share, like what you do in your practice, please feel free to share. Even it is like it will give us idea like what in which things we have to focus more, or in which part we can discuss. So it is like doing the teamwork, so that helping each other, like uplifting everyone and going in the same path.
I think they can unmute and talk directly, right? If somebody wish to chat in between, Kapil.
Yeah,
Yes,
yeah.
yes, sir. Yes,
That
sir.
will be, yeah, highly appreciated.
Yes. Yeah. So you come up with your question or suggestion. Probably we can have more discussion onto it. Yeah. So
I can see the Hira, sir. I don't know he joined the today session or not.
probably meantime the people coming up with question, I can add very small scope or kind of information here. So there are some patient classical patching, with classical patching they improve and somebody do not. So what actually goes wrong that somebody responds to it and somebody do not respond, apart from the compliance. So in spite of having compliance, you see that some patients do not respond to the component of any kind of penalization, whether it is a patching or you see bang filters or even atropine penalization. So to rule out or to understand the mechanism, you need to find out where the problem lies on that particular patient. So for example, if you are treating anisometric amblyopia, then you are trying to manage that condition, which is already the brain used to get some kind of information, and uh, so it's not a complete like reduction in the stimulus they used to get during the visual development phase. So with patching, you see limited improvement when it comes to anisometropic or isometropic cases. So there is no gold standard still now with the traditional mode. So you see data, you see patient doing alternate patching, but the improvement are not falling in that perspective of penalization therapy. But if you see a strabismic amblyopia, if you do a patching therapy, it improves to a large extent. Because of the non-fixation of the fovea. So the interocular dominancy, what you say, that is quite less. So what I'm trying to make you understand here is, suppose I have 6/6 vision in this eye, and due to anisometropy, I have around probably 6/12 or 6/18 vision. So there is still quite lot fight between two eyes in terms of the level of visual cortex, where the interocular competition it's quite high in this case. So the level of separation or the depth of amblyopia is more here. Because the vision is almost similar, but the competition is so high that when you give a patching therapy, it becomes difficult to break that one. Take the other case. I have 6/6 vision in this eye, but because of an squint or strabismus, I have probably 6/60 in this eye. Now you feel that this is more severe amblyopia, but the management is much simpler here. The reason being, this fovea and this eye fovea never competed. So the depth of separation is very less in this case, in this kind of amblyopia. So the moment you do a traditional treatment with the patching, the fovea suddenly or immediately recognizes or starts fixating and get the improvement quite fast. So this concept of the binocular competition when the amblyopia is happening is quite significant. And if you can rightly pick them up in the mode of management, then you will get nicer results. Having said that, when this group of patients you are trying to manage in the older age group, then anyway that long standing or long years of strabismus leads to binocular consequences. So it might be some extrafoveal point patient is getting used to with. Then it becomes difficult even in the case of strabismic amblyopia. So that time it is along with the depth of separation, it is the duration of the separation that plays an important role. So if summary is, if you can pick early a child with strabismic amblyopia and do occlusion therapy, they will show you excellent result as compared to isometropic or anisotropic amblyopia, where you will be doing an alternate patching or patching. So show a little slow progression in these cases. So this is based on complete clinical experience as well as some of the data which are available into it. And hardly you will see any data which is available into research domain on bilateral amblyopia, because this is the alternate patching is not so effective purely because of this aspect. Yeah, so now probably there are certain questions or suggestions.
Yes, thank you so much, sir. So, Ritu ma'am, can you see the question on the chat section?
Yeah, yes. I'm not having it. Okay. Classical patient with activities if no treatment after just for a month. As we choose particular treatment option, how much visual acuity improvement is considered significant to continue the treatment option? Does it differ with age? You mean to say how much we choose particular treatment option? How much visual acuity improvement? Okay, so in my today's lecture, I had like explained about the like classical treatment, like what used to be performed before. So ideally, that in our day-to-day practice, like we are not keen or we are not more focused only for visual acuity. We have to see their stropsis, we have to see their fusion, we have to see their accommodation versions and their motor skills. So considering all those facts, then we can see the where the treatment success or where the treatment has been success. So we have to consider all those things and then we can continue. But according to the visual acuity, like how much improvement is considered continuing that treatment option? Improvement is considered significant. So this one is like again it depends upon the age, but what I suggest, like rather than only considering only the visual acuity, we have to consider all these factors. Like for a normal individual, for everyone, like there should be a fusion. If they have suppression, hello.
Yes, ma'am.
Hello,
Yes, you
Kapil.
can hear.
Am
Yes, ma'am.
I audible?
Yes, ma'am. Yes, you are.
Yeah. So we have to consider all those factors. Then we can treat a child. So, sir, would you like to add some points on these questions?
I was muted. The approach is quite different for each individual or each practitioner. So if somebody wishes to target only the acuity gain, then it is limited to how much resolution acuity they are looking at for the particular patient. So especially you see whole domain of ophthalmologists, they look at only the acuity of the patient because so far the awareness they have created to the patient and everyone that okay, if the vision is improving, is going to be 6/6, that means you are out for amblyopia, which is not actually the case of amblyopia all about. So it's beyond the resolution acuity. You need to consider the other aspect of what Ritu mentioned about, that you look at the binocular vision parameters, you look at their accommodation, stereopsis, fusion, the saccadic pursuit skills, fine motor skills. So those are the things composite gives you the quality of vision. And now, when you treat with the traditional mode of patching and all those things, so you can work upon only the level of resolution acuity. So probably the next lecture will have more information where you will get in detail concept of how you can augment this traditional mode of management with a binocular approach, or if you wish to just completely shift to the binocular approach, how additive advantage it will have. So probably if people can look forward to the next session where Ritu is going to explain those component of improvement. So yes, if you ask me, then definitely it's not about the resolution acuity that we should look at. We should look at beyond it. But as of now, if you talk to any of the eye doctor or the patient, they are more focused how much the child is seeing, which is precisely the resolution acuity. So actually what the kind of vision that child should have, they are not bothered. It is how much acuity they have is mainly concerned about.
Thank you so much, sir. And next question is, with bilateral amblyopia of about 8 diopter each eye or more, do you do daily patching of 2 hours a day, each eye on the same day, or do it alternative days? Actually, truly speaking, I will I do, like in my clinic, in office therapy, like if I'm giving, I'll work on everything. I don't ask patient, okay, you have to do 2 hours patching or go home, do 6 hours patching. I don't do that. It depends upon practitioner to practitioner. But ideally, like when I'm giving therapy, I will work on everything. So like uh, with the help of non-amblyoptic eye, I'll treat the another eye. So I'll work on motor skills, I'll work on their bulgings, I'll work on accommodation and on their stereopsis, on their fusion. Um, so like mm, so treating, like I'll be considering both eyes and I'll treat on that. And even if
Right.
you are
So I think
patient,
in this, true, true, true. So
yeah,
when you have isometropic amblyopes, there is no standard guidelines so far. So patching predominantly works when there is still anisometropia or strabismus amblyopia, which is there. All guidelines from PDIG or pediatric investigator group, you see they mostly talk about anisometropes and strabismic amblyopia. But whenever it comes to isometropic amblyopia, so there is no clear consensus is what the mode of treatment is going to be, because it's not falling in that category of the monocular neural pathway. So when I say the monocular neural pathway and binocular neural pathway, so little different approach. So this treatment ideally should be in the base of binocular neural pathway to improve. Doing alternate patching again does not yield in great improvement. But the good part of it that this group of patients will have better binocular vision rather than the other group of patients. So if somebody can improve to 6/9 both the eyes with a good binocular vision is far superior result or a better quality of vision than somebody having 6 in both eyes but not having the binocular vision. So ultimate task as an optometrist is going to be how much quality of vision you can deliver rather than how much quantity of vision. So primarily we focus on the binocular vision aspect. So going forward, probably that's going to be a trends which we need to set ourselves and to the ophthalmic world, that yes, do not look at the quantity of vision, look for the quality of vision.
yes, absolutely. Yeah, that's true. We have to look for the quality. I think we got one more
Right.
question. Okay, yes, thank you. So now no more. Now we have not got any more questions.
Okay, ma'am. Ma'am, can we wait for a few minutes?
Sure, sure, sure.
Yeah. So can you see the one question over there?
So
Yeah. Agina mentioned example previously. If patient escapes patching for a day due to some reason, will it bring effect? So actually, in our what we had discussed, when we are working with a individual with like a child with the amblyopia, so here we are working with everything, with his fine motor, with his stereopsis, with his fusion, with like all the skills. So even if you are like what I feel, even if you are not asking him like, okay, you have to pass 2 hours, and suppose if that kid is not patching that day, and it's not like that all the treatment will not work. It's not like that. In my like when I'm treating the patient, like in office or even in home therapy, like the treatment approaches are different. That like I'm going to discuss in my next lecture. So what are the things we can go with our patients, or what we can do? So that time I think it will be more clear. I feel like that. So
correct. I think skipping a day of patching will not impact in that large way,
yeah,
provided the total duration of patching, what you suggest, the cumulative hours during the active time is more important. So in a week's time, if you're targeting of probably like 10 hours per week or 15 hours per week, so you set the trend at the during active phase of the child, how many hours you are targeting to patch. I think that is crucial rather than skipping a day, because usually on weekends and something when the child do not wish to patch, there is no worries. You just look at the cumulative hours.
Yes, yeah.
Okay. Waiting for another question. So we love to uh, see the question, or if we love to hear you from, if you can unmute yourself and push to the question. It could be from your regular practice, or either you can share your thoughts.
So probably I can have a question to all. When you treat some child with the traditional mode of amblyopia management, which is still the gold standard, which group of patient will show the kind of improvement, the fastest improvement, and why so? Is that understanding is very important. So it's not about question, it's about to understanding that why the patching therapy is still gold standard. So once you know that neural mechanism, why it is helping the patching therapy, and at which kind of patient it helps, I think that will be the outcome from today's lecture, that which group you need to target with patching and which is not. Absolutely do not try to do a patching, because that will not give you any results for that kind of patient. So there was some question popped out in between.
Yes, and the question is, let me read. In case of eccentric fixation, due to strabismus, traditionally a surgical approach and anti-suppression therapy used to work quite well. Any modern approach in such cases is recommended. Yes. In case of eccentric fixation, like due to strabismus, and if they have anti-suppression, so we should give the anti-suppression therapy. We should stimulate their fovea. So there are many therapy we have which we can do, we can give to our patient, and where we can work with their fusion, where we can work with their steropsis, and where we can work with their versions and steropsis as well, and even so many in office plus home therapy are there. Is from like we can give the Bionics home therapy or in office therapy. So over there also, like there are many like options are there where we can work in whole patient, like in overall in his motor skills, fine skills, versions, accommodation, right, sir? So
Absolutely. So, but one crucial aspect in eccentric fixators is, if you are planning to manage in younger age group, the prognosis is very good. But the moment that plasticity of the monocular neurons goes off, because eccentric fixation occurs in the primary neurons. So if that is happening, then it is, I would rather avoid giving any further management, because the chances of having monocular diplopia is very high for those group of patients. So they start seeing ghosting of images. But if it is still on the plasticity of monocular neurons, which is the age group of until 10 years or 12 years on some kids, so in those cases, yes, stimulate the fovea, stimulate, you can approach in a binocular manner, and they improve very good, or they shows very good results. But only thing you need to remember, the final yield in the monocular acuity is going to be determined by the amount of eccentricity still left to it. So for each degree of eccentricity, you expect that patient will have at least one logMAR line of less visual acuity than the better eye. So suppose you have around 2 degrees of eccentricity, you expect the vision is not going to be better than 0.8 anytime. So those are the consideration you need to like look at. So very crucial. The question and the understanding of this is, if you're targeting kids, yes, good prognosis. Adults, better not to try anything. As in, you can try, but chances taking that risk of monocular ghosting of images is likely. So you counsel the patient prior you are enrolling for any treatment approach for those group of patients, and if they agree with it, you start with. Now the best part, suppose somebody lands up in monocular ghosting, solution is very simple. You need to give a reverse dichoptic approach, and you put that eye into a suppression mode once again. So that is additional backup that you have.
Okay, thank you so much, sir. Thank you so much for your comment. So we are looking for another question. If anybody have the question, kindly drop on the chat box. I guess we are rounding up the session. So Ritu ma'am, do you have any good notes or any notes before ending the session?
Yes, Kapil. I would like to thank you, sir, um, so for being part of this session. It's great to see you here, and I would like to thank
Absolute
Kapil.
pleasure.
Yeah, I would like to thank Kapil, Mero Eye team, and all the participants over here. And please feel free to share what you are practicing or how you are doing, and like you can discuss. We have a group, so you can message there or you can message personally. No worries on that. Thank you very much, Kapil.
Thank you so much, ma'am. So Oli sir, do you like to add something before we wrap up the today's session?
Oh, absolutely! You guys are doing very good job. And what way I would like to hear more is from apart from this lectures. I'd request all the participants to come up with their unique cases, whether it is a success or a failure of those unique cases. Why there is a success and why you feel there is a failure. So we can discuss, deliberate, and then come to a solution. So that's going to be a more learning than just hearing from us only. So it should be exchange of knowledge among us, because I see most of practitioners are there, and there are upcoming practitioners onto this field. So you come up with those nice cases or questions. So you do a little bit of research and come up with all tricky question or all tricky cases rather. So if you have experience, and put up those kind of cases in front of your thing, your thought process, how you managed, and why there was certain deviation from the routine protocol. And that's going to give you the best clinical sharing of knowledge, I feel. So probably next session, more and more of this kind of cases is going to be appreciated. Thank you, guys.
Thank you so much, sir. So we didn't see any question till now. So here we, if you have any questions, again, you can Gmail to us, or we have a group, even you can drop on the group. So we'll be making everything, every technological thing good for study. So herewith, I announce the close of the today's session. Hope to see you all again next session. Thank you so much. Thank you so much, Oli sir, Ritu ma'am.
Thank you. Good night.
Thank you, Kapil. Thank you,
Good
sir.
night,
Good
guys.
night.
My
Take
pleasure.
care.
Bye bye. Take
Bye.
care.